Good morning, I'm Marta Massanella. I'm from Irsikasha. It's an institution that is dedicated to immunopathologies and is located in the IGTP campus at the Germans Trias y Pujol Hospital in Badalona, Spain. Today we will cover the long COVID. Long COVID is a new disease that is a post-viral syndrome that is caused by the SARS-CoV-2 virus, and we will talk specifically about the current challenges. First of all, I would like to thank Dr. Lourdes Mateo, who is an infectious disease physician and who is the coordinator of the Post-COVID Union and the research studies, that she's been helping us to put together to work. We have been working together in this new condition, and she's been visiting all the affected individuals. So first of all, I would like to start this presentation that by this sharing with you this article that it was written by one of our patients from our post-COVID unit, and I think it reflects really good the patient's feelings. What she says is SARS-CoV-2 infection didn't kill her but stopped her life, and I think it's a good beginning to see how long COVID patients they feel and how this disease has been they are invisible for the rest of the population. So, what is long COVID or post-COVID manifestation of COVID persistent? You see, there is a lot of names to name similar things. So, as most of us, we've been infected by SARS-CoV, we have suffered from a SARS-CoV-2 infection, and some of the, at least 10% of the individuals have persistent symptoms after 3 months post-infection. This persistent symptomatology has been prolonged for more than now 4 years. And one of the main problems that we've been facing in the post-COVID research is that we are mixing pears and apples. And why is that? Because the definition is not clear and is not unified within the health organizations. For example, the World Health Organization, the WHO, and states that the name is a post-COVID condition, and that means after the SARS-CoV-2 infection, it has to be more than 3 months of persistent symptoms to be considered a post-COVID condition. In the NICE, they separate like the phases in 3 phases. First, there is the acute COVID-19. Then there is a phase that you can have still persistent symptomatology that is called ongoing symptomatic COVID-19. And then after the 3 months, it's called the post-COVID-19 syndrome. In difference, the CDC and the NIH, they state the persistent symptomatology after 1 month of the initial infection. And what all the things they have in common is that the long COVID is after the 3 months. So it's really clear that after the 3 months of persistent symptomatology, we can call that a patient is affected by long COVID. But also there is another problem that the definition of long COVID is really vague, and there is a mixture of different other syndromes that can be intermingled. For example, the long COVID, it can last for years. There is no cure for so far, and there are no more biomarkers. But there are other syndromes that can have overlapping persistent symptomatology, as like the PICS, that is after the severe hospitalization in the ICU, that for being intubated or for a long time immobilized in the hospital, you can still have persistent symptoms, as they can be like fatigue or others that are really similar to long COVID. So after a severe COVID-19, you can develop PICS with overlapping symptoms, and then you can also have midterm sequels, that it can be alteration in the smell, the taste, and at the end, these symptoms and they resolve quite quickly after maybe 2 or 3 months post-infection. So one of the main problems and the first challenge that we are facing is that the definitions are really broad and imprecise, and they are not really a good definition. So what are the symptoms that they suffer, the individuals with long COVID? So basically, long COVID is a multisystemic disease. It can affect different organs like the heart, the lungs, also like with dyspnea or cough. Also, there is one of the main symptoms that is really predominant is the cognitive impairment with the classical brain fog, but also they have fatigue, memory loss, and tinnitus. The fatigue is really really also really prevalent in long COVID individuals. And also like there are persistent symptoms in the reproductive system with erectile dysfunction and also like irregular menstruation. Also in the gastrointestinal tract with abdominal pain or nausea, and also in the heart, like with chest pain and palpitation. As you can see, they're really broad, and it's a multisystemic disease. So one of the first things that in the research, what we've been trying to do is to classify the individuals according to their symptoms, because one of the main problems is that not all the individuals suffer from all the persistent symptoms. It's not like personalized. I mean, each individual, it's different. So in this study from the Recover, what is one of the biggest studies done so far, what they've been doing, what they did is to cluster the individuals according to the symptomatology. And what they see is they can cluster in 4 different clusters. The first one, that it's really the long COVID patients that they have not that severe long COVID, that they have alterations in the smell and the taste. Then we have a second cluster with post-exertional malaise and fatigue, a third cluster with brain fog, and then a fourth cluster with palpitation and gastrointestinal. And in our unit, what we've been doing in our unit is also like in a really well-characterized subset of long COVID patients. What we did is the physician interview all the patients, and they analyze like all the symptoms, persistent symptomatology, and we also saw 3 different clusters. And we also saw clusters that they are linked to severity of long COVID. We saw a first cluster that mainly they have fatigue, a second cluster that on top of the fatigue they have a neurocognitive alterations, dyspnea and maybe headaches, and then a third cluster that is the ones that have a really severe disease, long COVID, that they have fatigue, neurocognitive alterations, dyspnea, but also chest pain, tachycardias, neurosensitive alteration, and the list is really long. In this cluster, more than 20 symptoms concomitantly can suffer these individuals. So I hope that I convince you that the second challenge that we are facing is that it's really non-specific, and this makes really hard to do research and to be unified. So, and another problem is that we are lacking of biomarkers. So far, there has not been a diagnostic biomarkers. So the diagnosis is done clinically and by exclusion of other pathologies. And so the patients arrive to our unit and they tell us that they have like a subjective symptom. No, they describe directly by the patient that they have brain fog or palpitations, but we don't have an objective thing. So we need to start thinking to change from the subjective that I love oranges, no, to these are oranges. And this can be different. We can do it different forms by biomarkers. And when we're thinking of biomarkers, we don't only think about the immunological that they are the most common, but also clinical or images or even genetic. And one of the problems that we have in defining the biomarkers is the identification, because of course, as I was telling you before, it's not the same to have the post-unit ICU syndrome, the ones that they have been hospitalized and really severe, compared to the ones that they have had mild COVID. So we need to be able to distinguish the sequels from the long COVID. And also to identify biomarkers, especially the ones that we can test in blood. And we need to have several things into account. All the studies that we've been doing, no, like the different studies, the time post-infection, it's really important. Also, if the individuals have been reinfected, because as you may know, I mean, SARS-CoV-2 is still here and a lot of people get reinfected. So it's really important when we're trying to address in research some biomarker to take into account the reinfection, because when the virus starts again, it can be another response against the virus, and then the immune system it will be altered. Also the time post-vaccination, and also if the patients with long COVID, they have a symptomatic treatment, no? And these make a little challenge to identify different immunological alterations, because when there is a new reinfection or a vaccine or even a treatment, we remove the water that is dirty, and then we need several time to cool down and to identify what is really left, and that could be an objective biomarker. So what are the hypotheses behind the long COVID symptomatology? So there are different ones, and they are not mutually exclusive. So in first place, we can have a systemic and tissue-specific inflammation. Also, it's been proposed that there are a human herpes virus reactivation. Also, what it's really now ongoing with ongoing research is the persistence of viral antigen or viral particles. Also, what is clear, there is a microbiota dysbiosis. Also, another hypothesis is the autoimmunity. It's been clear also there have been a lot of endothelial abnormalities. Also, a dysfunctional neurological signaling and metabolic dysfunctions. And as I was telling, these hypotheses are not mutually exclusive. So it can be that they're interconnected and makes really hard to get a final origin of this persistent symptomatology. So adding on the non-specificity of the disease, we don't have any diagnostic or prognostic biomarkers, which makes this disease even more complicated. So what are the risk factors for long COVID? So also, as the definition has been really wide during the last 4 years, they have been different studies, but the results are not always in agreement. So, for example, in this study that they were looking 4 weeks post-infection, what it was clear, it was that the being male was protective of long COVID. So being a female, you have more risk to develop long COVID. And other comorbidities that they were related to a severe COVID-19, the acute phase, they were not related to long COVID. In this other study, and that they look at 4 weeks after infection, what it was clear that being a female and age over 40 years old, and there were risk factors to develop long COVID, and in the other hand, to be a graduate education and urban residents, they were protective. In another study, when they were looking at 12 weeks after infection, again, the female was the one that increased the risk of developing long COVID. And then when they compare at the age, so being younger and older, there were like protective things. However, like the ethnicity, being Black or Afro-American, increased the risk of developing long COVID, also being smoker or being in socioeconomic deprivation. In terms of comorbidities, there were some comorbidities that were linked to increased risk to develop long COVID, and also like fibromyalgia, anxiety or depression, or migraine, they were like linked to increased risk of long COVID. So in these meta-analysis studies, they put together all the information that I've been telling you to now. And at the end, when they put all the studies together, they revealed that age was not associated to develop long COVID, but the only thing that was really clear is that the female sex was associated to develop long COVID. So this is the only risk factor that it's really clear among all the studies. So the third challenge that we are facing is that risk factors are really unknown. Female is the only one that is not controversial, but the other ones are really controversial. So how about the prevalence? Because we've been talking about this disease, but what is the risk to develop long COVID? So in this meta-analysis, they took all the studies that have been done so far, and they identified that the global prevalence was at 43%. That's really a lot, meaning that 43% of the individuals who get infected with SARS-CoV-2 may have persistent symptomatology. When they subclassify by hospitalized versus non-hospitalized, the risk to develop a long COVID it's higher if you've been hospitalized compared to the non-hospitalized. In in this study that is one of the biggest ones done so far, they evaluated like the prevalence of long COVID according to the variant of the SARS-CoV-2, because we have been exposed to different variants, and basically what they saw that is that Omicron has lower risk to develop a long COVID, but we don't know if it's a vaccination problem or it's Omicron that leads to less risk of developing long COVID. Because when we look at the personal vaccination to be complete vaccinated, it really decreases the risk of developing long COVID. So continuing with the vaccination, we can clearly see that it's like the vaccination with any kind of vaccine reduces the risk of long COVID. And this was done in 4 large cohorts of patients from the UK, from Catalonia, and from Estonia, with millions of data. So it's really clear that it's really important to get vaccinated against SARS-CoV-2 to decrease the risk of developing long COVID. How about reinfections? Because it's a thing that we are still facing, like the SARS-CoV-2 still here. So reinfection increase the risk of all-cause mortality, increase the risk of hospitalization, and increase also the risk to get one sequel. So I think what is really clear is that we are facing a 4th challenge, that the prevalence and the incidence are still unknown. There are a lot of variation between studies. It's clear that vaccination has reduced the risk to develop long COVID. It seems that Omicron can have, like, or the newer variants have less prevalence of long COVID, but it's still we need to do more research to be sure of these results. So how about if we treat COVID-19 during the acute phase in terms of long COVID? So what was done in this study is they treated with 2 antivirals, nirmatrelvir and ritonavir, during the acute infection, and they found that there was a decrease in the risk of developing long COVID. However, in a later study, and that they designed to have a matched cohort to emulate like a randomized control trial, versus using nirmatrelvir and ritonavir versus no treatment in non-hospitalized patients, only found in a decrease in the incidence of thromboembolic events, but not in the development of long COVID. In this study, they use instead of they use the ensiltrelavir, that is another antiviral, and they found that the patients that they were treated had less symptoms than the placebo after 85 days, 169 days, and almost 1 year after the infection. So it seems that treating during the acute phase the COVID may also reduce the risk to develop long COVID. In another study, what they use is metformin, and to see which is the impact to reduce long COVID, and it was clear that if the metformin is given during the first 3 days of infection, it also can reduce the risk of long COVID. So the 5th challenge is to find new treatments on acute COVID and to be able to reduce the risk on long COVID. And the studies, I show you some of them, but there have been more, and also they've been contradictory results. So we need to do like really well characterized randomized clinical trials to be able to confirm that one agent or one drug can reduce the risk of developing long COVID. So in this study, how about the recovery? Is it really common to recover from long COVID? So in this study from the post-COVID group on hospitalized patients, only 30% of the patients consider themselves completely recovered after 1 year. And the factors associated with non-recovery were female, invasive mechanical ventilation, and obesity. In this another study, and that they look at the recovery after 18 months, 6% had not recovered at all from the persistent symptomatology, and 42% had the recovery was partial. And the factors associated with the non-recovery were again being female, being older age, being white, hospitalized, non-vaccinated, and a history of previous respiratory disease or depression. In our study that we developed in our unit, we look after 2 years from initial SARS-CoV-2 infection, and looking at 341 patients, and only 7% were recovered. So it's a really low percentage of recovery. And we look at what are the symptoms at the beginning, from the acute infections, that they were protective, contrast the symptoms that the patients were suffering in the acute infection, that they were higher risk to develop long COVID. So if the patients had in the acute infection alterations of smell and taste and hyporexia, they were more likely to recover. In contrast, if they have myalgia, dyspnea, tachycardia, or neurocognitive disorders, they were less likely to recover. So another challenge that we are facing is that the recovery of long COVID is really, really low. So we have a high percentage of individuals that might have long COVID and a really low recovery. So I hope that this convinces you that we are facing a new public health issue. So talking about public health issue, which is the economic impact of long COVID. So people think that maybe long COVID it's a mild disease, but it's not, because 53% of individuals affected by long COVID, they had unemployment affected. A lot of them had to reduce the working hours, and others had even to stop working because they were not able to work anymore. They were too sick to be able to work. So at the end, this is a long-term disability, and it's really clear in the study that they were looking at the monthly work income of people that they were in long COVID or not, and they can clearly see that people with long COVID, after 2 years, they have really less income than the people that they don't have persistent symptoms. So it's really that it's a really economical impact of long COVID. And it's because mainly that the most affected population is around 40 to 50 years old. So it's a population that are in the working age. How about the healthcare cost? So the healthcare cost that is associated by the visit, the test, and the treatment that have to receive the patients, it's really high in this population. So there is a really high increase in the test and the cost of the long COVID patients compared to the ones that don't have persistent symptomatology. So at the end, long COVID has a really economic impact. First, because of the employment. Then it puts a lot of pressure to the healthcare systems, and also a social issue because they cannot work, and also it's depressing for them. So at the end, we are facing a new global health problem. And actually, in this editorial from Nature from last year, they put like in numbers what is long COVID compared to other pathologies, and it's estimated that nowadays there are 65 million of people with long COVID around the world, and it's expected that in 10 years the incidence, taking into account of incidence of 5%, that it's lower than what it's counted now, they expect that there will be more than 200 million people affected with long COVID. And this number is really similar to the one that is affected with ischemic heart diseases. So we are getting to similar numbers with one of the most high priority medical conditions and that we are facing right now. So I hope I have convinced you that we need clinical trials to treat these patients, and we need to find a solution for them. So in this editorial, it was stated that there are too many to ignore. So just the sixth challenge is we have a population with high disability, and there is a high economic impact. So just to sum up what we've been defining to now, and the first challenge is the definition, that it's really broad and imprecise. The symptoms, as I showed you during the presentation, they are imprecise and there are different phenotypes, so not all the individuals are facing the same persistent symptomatology. The biomarkers to diagnose or to the prognostic biomarkers are inconsistent, and there is a lack, there are not any. The risk factors, the only one that is clear is being female has higher risk to develop long COVID, but the rest are unknown. And the recovery, it's really low. And the treatment, so far, there are none that has been proved to be working. And the economic impact is really high. So I hope I convince you that this is a global health problem that we need to face really rapidly and to work together. And that, like the patient care, it's working together with the research to be able to solve this, find a solution for these patients. So I would like to thank all the people involved in the post-COVID condition unit here at our hospital, and thank you for listening.